Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 19.0, which is Hematology, Hemostasis, and Thrombosis. We are streaming live from IMS and some hospital, Bhubaneswar via Kolkata. A very interesting topic, circulating anticoagulants, which is inhibitors, and antibody-mediated coagulation factor deficiencies. And to talk on that, we have once again Dr. Rajesh Kumar Bhola, who is an expert in hematology and more so on hemostasis and thrombosis. He is an MD Path with fellowship in lab hematology from the famous CMC Vellore. Presently, he is an associate professor and in charge Laboratory Hematology Division, Department of Pathology at the famous IMS and SOM Hospital, Siksha or Anusandhan, deemed to be University Bhubaneswar, Odisha. His areas of interest is Haematolymphoid neoplasms, flow cytometry, coagulation, and laboratory automation. He is credited to be the person who has established the Laboratory Hematology Department as a center of excellence in Odisha, received the Times Healthcare Icon Award in 2019 for medical excellence in the field of hematology in Odisha, with best paper presentation in APCON 2011 Odisha chapter. He's got multiple international and national publication and also is the lead site investigator for various international collaborative projects. Before I ask Dr. Bhola to start, let me request all of you to keep your mic muted, your camera off, and please do not share your screen. With this, let me request Dr. Rajesh Bhola, sir, please share your screen. We are ready to go.
Thank you, Dr. Said, for your nice introduction and good evening, everyone. My screen is coming.
Yes, sir, just share your PowerPoint.
Yeah, it's coming. And I think at the outset, I would like to thank Dr. Said and the team Pursue for giving me the opportunity to talk on one of the very important aspects in coagulation, which you can say is less explored in a lab, but can be very well possible in any of the lab to look into circulating anticoagulants. So today's topic will be on circulating anticoagulants or inhibitors, and to be very specific on antibody-mediated coagulation factor deficiency. So my objective for today will give you an overview of what are circulating anticoagulants, what are the laboratory tests that can be done and how you are going to interpret it, and what are different guidelines suggest about it. So when we talk about anticoagulants, something that comes to our mind is that is present as a natural anticoagulant, which is naturally inhibiting any coagulation process or clotting process inside the body, or there are some acquired anticoagulants which is preventing the coagulation factors from forming a clot. So you can divide it into circulating anticoagulants as an inhibitor of the coagulation factors naturally occurring, or as an antibodies that neutralize specific clotting protein, thereby interfering its normal function. So broadly, you are classifying it to it, or we can classify into natural inhibitors versus acquired inhibitors. And when we talk about the acquired inhibitors, they can be again of three broad categories, that is allo antibodies, auto antibodies, and a specific type of antiphospholipid antibodies. So, what are the allo antibodies? These are the inhibitors that develop in patients of Hemophilia A or Hemophilia B or any known coagulation factor deficiency. When they are being treated with the factor replacement, they develop antibodies against those factors, then we call them allo antibodies. And what is autoantibodies? The patient is not a known case of a coagulation factor deficiency, but there are developing or acquiring autoantibodies against coagulation factors later on, and then we call them as an autoantibody. So my presentation will focus more on these antibodies, not on the natural inhibitors that you are very well versed during the physiology, a discussion of the physiology of the coagulation pathway. Coming to a case scenario, here is a 15-year boy who has been referred to our hospital because of an intracranial bleed, and he is a known case of hemophilia A. And whenever patients are being referred who are known case and under known factor replacement, something that comes to your mind is that does this time factor is going to act, or something will prevent the factor replacement from its actual action. So, whatever may be the case, you have to first evaluate laboratory wise. And when we have evaluated laboratory wise, the hemoglobin is 11.5, WBC is 11,400, platelet appears normal, PT is normal because it's a hemophilia A case where there is a factor 8 deficiency is there. So, PT will not be prolonged and APTT is prolonged. Then how do we know that this appetite which is being prolonged is actually because of a factor deficiency, or there is some inhibitors that act against those factors? So the my question here is what next? So in this scenario, whenever you find whether this is the first time or you are looking into a follow-up case, whenever your PT or a PTT or a thrombin time, which are your basic coagulation test, they are being prolonged, one of the common step that you should perform in your lab is mixing study. That's what we performed in our lab, and an epitaty mix with the PNP, that is pooled normal plasma, shows it to be still prolonged, that is 52.5 seconds against a control of 29 seconds. So, which shows with a PNP mixer there is no correction. So, what is this mixing study? So mixing study means you are bringing two kinds of plasma and you are mixing and making it one sample and do the tests. So what are those two plasma? One is the plasma of the patient which is in focus. Another, you have a prepared plasma from a normal samples. Then we call it pool normal plasma. And what is the principle of this mixing study is that whenever factor levels are at least 50% of the normal, that means 50% of any factor, they can give you either a normal PT or a normal APTT. Then how you are achieving this? We are achieving by mixing a patient's plasma and a control plasma, where the control plasma is a pooled normal plasma, where we have pooled at least some 20 normal samples together. What is the basis of it? If you go by the reference range of any normal coagulation labels, it varies from 50 to 150. That means in a normally distributed population, you will get value from 50 to 150 with a mean value of 100. So that indicates a normal pooled plasma. If you prepare by mixing the 20 samples, each of the factor level within the normal plasma will be 100%. Suppose an example of a patient who is having a factor 8 level which is less than 1%, and you are doing a 50-50 mixture. That means 50 per one sample which has less than 1% factor levels, and the other sample which is having 100% of the factor, you are taking 50 out of it. So you are making a mixture which has at least the factor level equal to 50%, and by principle this will achieve you a normal PT or APTT if there is a factor deficient that is being corrected by addition of a full normal plasma. So how this full normal plasma is being prepared? At least you have to take 20 normal healthy individuals who are not taking any medications that can interfere with the clotting factors and coagulation reaction. And priorly, it was not acceptable to take females with oral contraceptives, but now you can take, but better you can avoid. But if that is not possible, you can take women who are taking oral contraceptives, and you have to take equal number of male and equal number of female, and the age range should be within 20 to 50 years. You prepare the PNP, froze it, keep it, and whenever you have a abnormal PT or APTT, do a mixing study to see whether there is a factor deficiency is there or there is an inhibitor is present against the coagulation factor. So, looking at this cartoon, let's understand what will happen when only factor deficient plasma of the patient versus patients who have a inhibitor against coagulation factor. The first picture, if you look into the patient sample, you have some of the circulating antibodies, and the circulating antibodies are either the free circulating antibodies or they are bound against these blue dots, which are actually coagulation factor and inhibiting them from its action. In the second patient, you have no coagulation factor and like no factor 8, suppose it's a hemophilia A, and you also don't have any antibody. Now you do a 50-50 mixture of patient and normal plasma. Normal plasma has at least 100% of the all the factor labels. And when you did a mixture in the first case, which have inhibitor against the factor 8, you find that whatever the free antibodies are there, they're now binding to the factor that is being supplied by the PNP. And if you do a APTT in this case, the APTT will happens to be prolonged. Looking into the second sample, where patient has only factor deficiency and you are not finding any antibodies at all, you mix it with a normal PNP and you see that you have at least 50% out of this 6 numbers blue dot that has become 3 blue dot. That means there is only 50% of the factor 8 is now there in the mixture, and it will show a normal APTT value or the near normal APTT value. So that means correction is there. So doing mixing study, you have two scenarios, whether correction is happening or correction is not happening. If correction is happening, means normalization or near normalization is happening, then patient is having a factor deficiency. If correction is not happening, then patient is having an inhibitor against the coagulation factor. So this simple study, everybody can perform in any, even a manual doing a lab doing manual test can also perform, can differentiate between whether patient have a factor deficiency or an inhibitor against coagulation factor. So that should be the basic principle of any lab. Whenever you have a prolonged PT and APTT or TT, do a repeat with 1:1 mix, that is patient with a control plasma. If there is a complete correction there that indicates factor deficiency, can be a single factor deficiency or a multiple factor deficiency like a vitamin K deficiency related factor deficiency or a liver hepatic disease related factor deficiency. So that indicates there is a decreased synthesis or there is a depletion or there is a dilution. Whenever there is a partial correction or no correction, there is circulating anticoagulants. And what is the source of these circulating anticoagulants? They can be FDP, fibrin degradation product. And where do you find those cases? Specifically in cases of patients with a DIC. So a patient with DIC, you can find a PT, APTT, TT, all are prolonged. And if you are doing a mixing study, mixing may not correct. Patient with heparin anticoagulation will also show a prolongation that may not show a correction. And antiphospholipid antibody, if you are using a low phospholipid containing reagent, you can have a prolonged the APTT. And if there is a specific antibody against the coagulation factor, there will be also a partial correction. So this simple test of mixing can help you in differentiating whether you are dealing with a factor deficiency versus a circulating anticoagulant. So with this, we will focus on first type of antibodies. Those are allo antibodies. And because hemophilia A is the most common inherited bleeding disorder, my initial presentation will focus on antibodies against factor 8 or factor 8 inhibitors. So what happens in hemophilia A? Hemophilia A patients, you are going to treat those patients with factor 8 replacement, and whenever they are replaced, some of the patients can develop antibodies against factor 8. And once these antibodies are developed in those patients, they will prevent the replace factor 8 from acting, and so that the bleeding will continue. And what is the prevalence of the formation of allo antibodies in hemophilia A patients? The prevalence is almost 6 to 20%. And to note from the very beginning, a factor 8 inhibitor that is being developing in hemophilia A patients are time and temperature dependent inhibitor. That means there are some inhibitors are there which are not time dependent. So where will you find which are the inhibitors that is not time dependent is a hemophilia B cases or other factor inhibitors. Okay. To understand in detail why and how these inhibitors are developing, we need to understand the factor 8 gene and the factor 8 protein. A factor 8 gene is located in the X chromosome in its long arm that is on XQ28. And the structure of the factor 8 gene is very large, almost 186 kilobase long gene it is, and it contains 26 exons. And in the 26 exons, near the 22 exon, there is a 22 intron site, has a area for factor 8A and factor 8B. Why I am focusing on this area? Because this is the most common area where an inversion happens, that is inversion 22, and it is one of the common genetic abnormality leading to hemophilia A, and this common genetic abnormality is also more commonly seen associated with development of inhibitors. The second picture shows the transcription of mRNA with the two non-coding region, that is the 5' untranslated region UTR and 3' UTR region with a 9 kilobase intervening sequence. And the factor 8 protein, that is also a large protein consisting of 2332 amino acids. And it has 3 A domains, 1 B domain, and 2 C domains. These 3 A domains are A1, A2, and A3. And the B domain sits in between A2 and A3. And beyond A3, there is the C1 and C2 domain. And there are 3 small breakpoints which are being designated A1, A2, and A3 in the small letter. Why this structure is important? This structure in an inactive state actually forms the site for adhesion of your von Willebrand factor, and they also provide the site for the attachment of either activated factor 9 or activated factor 10 or thrombin. So in an inactive state, the von Willebrand factor is attached to the A3 and the C2 domain that you can see as shown in the figure D. And what happens whenever there is a protein activation by the thrombin cleavage, this von Willebrand factor gets dissociated from this A3 and C2 domain. Now, what the protein you are getting is a activated factor 8 protein. So remember this, because when we will start discussing about the inhibitor development, this inhibitor development is actually they developing against these A1, A2 or A3 A domains, and which prevent or which do a steric hindrance for action of the factor 8, leading to for functional factor 8 deficiency even in a replacement therapy cases. So, as you have now understood, hemophilia A is an inherited X-linked bleeding disorder where males are affected and females are carrier because of deficiency of coagulation factor 8 due to mutation in the factor 8 gene. And it affects 1 in 5,000 to 10,000 newborn males worldwide. And the main determinant of the bleeding phenotype depends upon the level of the factor 8. And depending upon the level of the factor 8, it can be classified into mild, moderate, and severe. Severe is less than 1% of the factor 8 activity that is elicited. Moderate is 1 to 5%, and the mild is 5 to 40% of the factor 8 activity. And what are the common clinical presentation in case of say hemophilia A? They present with a deep bleed. Deep bleed means bleeding into the joints, hematrosis or deep muscle bleed or subcutaneous hematoma can happen in some of the cases. And how these patients are being treated? These patients are being treated with factor 8 concentrates. And what are the source of factor 8 concentrates? They can be either derived from the plasma, then we call it plasma derived factor 8, or they can be a recombinant factor 8. So you should also remember this, because this also can be a determinant of the development of inhibitors. And the treatment is done by intravenous infusion of the factor 8 products. And when do you treat? Either you treat on demand when patients are presenting with bleeding manifestations, or you can treat on a prophylactic basis where you are giving a low dose factor 8 at a regular interval so the patients may not develop any bleeding manifestations. So that two modalities of treatment, on demand or on prophylactic basis, and two types of concentrate, plasma derived or recombinant. And what is the main complications of factor replacement therapy? A is development of neutralizing allo antibodies is the main treatment related complication in patients with severe hemophilia A. So what happens during initial administration when you are doing a factor 8 patient usually presenting to you in a state of hematrosis or a subcutaneous hematoma or a muscle hematoma, so it is in a state of inflammation, and this inflammation actually leads to the different pro-inflammatory aggravates pro-inflammatory response even during a factor replacement. And this pro-inflammatory response is the inciting point for development of antibodies against the factor 8. And once these antibodies are developed, the inhibitors are developed, they can bind to the factor 8 epitope, neutralizing the therapeutic activity of the infused protein, leading to bleeding that is difficult to control. And the cumulative incidence, as I have already mentioned, can develop in a patient with hemophilia A, can vary from 20 to 35%. And in about 95% patients with hemophilia A who develop inhibitor, it occurs within first 75 exposure days of factor 8 replacement. So if they are not developing initially, so there is a chance that there is, may not develop a factor 8, or there is a less chance of developing inhibitor later on. So what is the definition of an inhibitor, or how do they differ in case of hemophilia A from other cases? These inhibitors are a polyclonal high affinity immunoglobulin G type. That means the inhibitors which are IgM or A in nature may not be directed against the factor 8 protein or may not inhibit the factor 8 functionality. And the majority of these G are IgG4 antibodies is the predominant nature, and as you know, G4 do not fix complement. And this formation of the factor 8 inhibitor is a T cell dependent event that includes antigen presentation, followed by the T helper cell lymphocyte activation and activation of the B lymphocyte, and plasma cell differentiation and formation of the antibodies. And the antibodies which are developing in case of hemophilia A because of the therapy or any other even hemophilia B or other factor deficiencies can be either inhibitory in nature or non-inhibitory in nature. So not necessarily that always the antibodies will inhibit its functional activity. And inhibitory antibodies are primarily directed against the A2, A3 and C2 domain, as I have already told in the initial slides. And these domains interfere or they produce a steric hindrance blocking the functional epitopes of factor 8, by which the factor 9 phospholipid vonulibrin factors can no longer attach to it and to show its action, and there will be bleeding episodes. So antibodies in inhibitor patient can simultaneously target multiple epitopes, and these target epitopes can also change over the time. Based upon the type of inhibitors, they can that is the kinetics of the inhibitor and the extent of inhibition of the factor 8, they can be also categorized into two categories: type 1 inhibitor and type 2 inhibitor. Type 1 inhibitor follows second order kinetics, means they follow a dose dependent linear inhibition of the factor 8. They completely inactivate factor 8, and they're more commonly seen in severe hemophilia. But in comparison, type 2 inhibitors have complex kinetics. They are incompletely inactivating the factor 8s, and they're more common in inhibitor patients with mild hemophilia or patients who do not have hemophilia later on developing an acquired hemophilia, that is autoantibody development. So, how do you then characterize an inhibitor? What is the answer? The first step is mixing study. But when we do a mixing study, what I have told you is that the inhibitors in hemophilia A are time and temperature dependent. So when you screen for the inhibitor, you have to keep that in mind, and you have to design your screening test in such a way that it can depict the time dependence and the temperature dependence. So that is the reason the inhibitor screening done in a hemophilia A or hemophilia B should have two basic steps. One step is doing an immediate mix. Second step is doing an incubated mix. Incubation allows to show the time dependence, because you are incubating for certain time and you are incubating at a particular temperature, so it is showing you the temperature dependence. First, you will take a patient's plasma, the normal pooled plasma, and in the C, the third tube, you are doing an 1:1 mixture. You test all and you compare all. Then you incubate all. Once you are incubating for at least 2 hours. Some lab or our lab do an incubation of 1 hour and 2 hour and do the mixing study after 1 hour and 2 hour too. But otherwise, you can do after 2 hour incubation. You can test the 2 hour incubated mix, and because you want to show the temperature with temperature factor 8 is a temperature with time factor 8 levels will also reduce, so you are incubating the patient and normal plasma. You can do a fresh mix after the 2 hour incubation. That is your D, that is the control. Now you compare C and D, and now you can interpret if C is showing you non-correct correction, so that indicates there is a time and temperature dependency is there. So a difference of more than 10 seconds between a fresh mix and an incubated mix is considered positive. But if you want to make your screening test more robust, you can take a cutoff of 8 seconds. That's what we follow in our lab. We take a 8-second cutoff wherever we go for further step testing to detect inhibitors. There are different complex formulas are there. Those can be used to look for the presence of inhibitor. One formula is Chang's formula, one is Rosner's index. Chang's formula, the formula that you have to take patients by APTT minus 1:1 mix APTT divided by patient's APTT minus the control normal plasma APTT 100. Inhibitors are there if the value is less than 58%. Inhibitors are not there, factor deficiency is the cause of it, then it is more than 70%. 58 to 70% are the borderline values. In Rosner's index, how do you calculate? You do a 1:1 mix APTT minus the control normal plasma APTT divided by the patient's APTT into 100. Inhibitors are there if more than 15% value is being reported. But more simple approach is just do a mixing study like this, where you have taken the 1, 2, 3 types of sample is being depicted over here. A is a normal plasma, B is the test plasma, C is test plus PNP, that is incubated mix after 2 hours, and the 1 hour. Take a D is test plus PNP incubated separately before mix, that is your fresh mix after, sorry, not 1 hour, 2 hours, and let's interpret. In the scenario 1, you have a normal plasma which is 40 seconds with the test plasma 90 seconds. You are doing an incubated mix which is showing 45 seconds and fresh mix also showing a 45 seconds. That means it is showing correction. So there is no inhibitor are there. It is just because of an intrinsic defect. In the second sample, you have a normal plasma which is showing 40 seconds, test plasma 90 seconds. You did an incubated mix which is showing 70 seconds and the fresh mix which is 40 seconds. 70 minus 48 is 22, that means more than 10. So it indicates that the inhibitors are time dependent inhibitors. So there is a factor 8 inhibitors are there because factor 8 is a time and temperature dependent inhibitor. In the third case, you have a normal plasma 40, test plasma 90. You did a incubated mix is which is showing 70, no correction. Fresh mix showing 70, no correction. So that indicates that there is an immediate acting inhibitor, and mostly this kind of inhibitor you will find with the Hemophilia B or other factor deficiency. But note that a high level of inhibitor in a Hemophilia A patient can also show no correction in the immediate mix. So whenever immediate mix shows no correction, that means there is an inhibitor. And if you are dealing with a Hemophilia A patients, known Hemophilia A patients, so there is a factor 8 inhibitor is there. So who should undergo inhibitor tests? So there are some guidelines are there. Among the severely Hemophilia A or B patient, every third exposure day or every 3 months until the 20th exposure day, one should undergo. Second, after 20th exposure day, every 3 to 6 months up to 150 exposure days. Third, hemophilia A patients who are under factor replacement, they should undergo annual inhibitor test screening. Hemophilia B, they should be tested after 150 exposure days, is only required if clinically indicated. Hemo inhibitor test should also be done before any change in the concentrate, that is either plasma derived to your recombinant or recombinant to plasma derived, at least twice in the first 6 months after the change, and if there is any change in the bleeding pattern or in response to factor 8 is there, then one should do a inhibitor testing. Among the mild and moderate hemophilia patients, yearly or after the intensive exposure, that is 5 exposure days, or after surgery or before surgery, a mutation with high inhibitor prevalence or a family history of inhibitors should undergo inhibitor testing. Hemophilia B should be tested after an allergic reaction or a replacement therapy. They should also be tested with an inhibitor test. So what next? Once you find that your inhibitor screen is positive, you have to do a inhibitor assay. What is the basic principle of inhibitor assay? It has a test reaction and a control reaction, where in the test reaction you are adding patient's plasma with the pooled normal plasma, and in the control reaction you are just adding the buffer, and you are measuring the clot formation. So you are doing an APTT like assay in a case, or APTT based assay in a case of hemophilia A or hemophilia B. If you are dealing with a factor 7 deficiency, you can do a PT based assay. Now you compare the amount of the factor 8 or factor 9 in the test reaction with the control reaction to reflect the strength of the inhibitor in the patient's sample. And from there, you can calculate the inhibitor level. So this is the basic principle of the inhibitor assay. And the inhibitor assay was first reported in late back in 1959 by Biggs and Bidwell, where they have done a two-stage factor 8 assay. Followed by a Bethesda assay has been performed by the Casper et al., where they have done a one-stage assay for factor 8 after doing a 2-hour incubation with the pooled normal plasma. So they established the Bethesda unit for measurement. And there is a modification that is done in a Nijmegen's assay by the Verbruggen et al. Group. And they have done a modification by adding buffered pooled normal plasma and diluting with a factor 8 deficient plasma. That makes it an expensive affair, but it makes them more sensitive and specific, and it is now being considered the gold standard for inhibitor testing. So how they are being measured? The inhibitors are measured by a Bethesda unit in Nijmegen's assay by Nijmegen's Bethesda unit, or NBU. And what does the Bethesda unit depicts? One Bethesda unit of inhibitor is defined as the amount that will inactivate 50% of the factor 8 activity present. So means suppose your pooled normal plasma is 100%, one Bethesda unit in the patient's plasma will reduce it to 50%. So that is what is the depiction of one Bethesda unit. So what is the difference? The difference between the classical Bethesda assay versus the Nijmegen's Bethesda assay, as you can see, you have a patient's plasma, pooled normal plasma, and an imidazole buffer in the Bethesda assay at pH 7.4, and you have a test mixture and a control mixture. Now you are looking into the factor 8 activity by doing a serial dilution and calculating the inhibitor levels. And in Nijmegen's assay, you have a patient's plasma, and now you are taking a normal plasma which you have done a buffering to achieve a pH of 7.4, and you have a factor 8 deficient plasma. In the control mixture, you have added the buffer plasma and deficient plasma. In the test mixture, you have the buffer and the normal plasma. Now you are incubating, and now you are doing a serial dilution and calculation of the inhibitor levels that is being expressed. Then how do you calculate? You calculate based upon the principle is that factor 8 inactivation will increase with pH and reduce protein concentration. Sorry. Why you want a Nijmegen's assay? Because factor 8 inactivation increases with the pH and reduce protein concentration. That can lead to a false positive raise in the classical assay. So that is the reason Nijmegen's assay is your gold standard. And you are calculating from this graph. So from this graph, suppose your factor 8 residual factor 8 activity is 50%, What is your Bethesda label or inhibitor label? 1 Bethesda unit. If your residual factor VIII activity is 60%, that indicates 0.75 Bethesda unit. If your residual activity is 36%, that indicates 1.475, and for corresponding 30% residual activity, 1.75. So from this graph, you can see that you can deduce the inhibitor labels if you can calculate the residual factor VIII labels in the control plasma and the patient's plasma mixture. So that's what we do by doing a serial dilution of patient's plasma of one neat, 1:2, 1:4, 1:8, like that. That means we are serially diluting the inhibitor levels. Now we are doing a mixing study with the control plasma pair, and the control plasma has a factor VIII activity nearly 100%. With the mixing, it is 50% half. Now, this label will be reduced by the action of your inhibitors present in patient's plasma. Because you have serially diluted, you are determining a dilution which is closest to the 50% residual factor VIII activity. And what I have told, one Bethesda unit will cause factor VIII labels or reduce the factor VIII labels to 50%. So whichever is nearer to the 50% is closest to one Bethesda unit. With the multiplication of the dilution factor, you can now calculate the levels of the Bethesda unit or the levels of the inhibitor present in the patient's sample. You have to remember that the residual factor VIII activity should be greater than 25% and lesser than 75% to interpret, and the control value should be more than 80% and to do any interpretation. Let's look at an example what we have done in our lab. So that is your the case 1. We have done a dilution of the test where, and now we have done a mixing. So first tube is the control plus buffer, so that indicates only the control factor VIII labels. You do a multiplication by the 2, that is your factor VIII factor labels in the control sample, followed by the second tube control plus test, third is a half test, 1/4 test, 1/8 test. So like that you have done a serial dilution. Let's see what is the factor VIII activity we get in different levels of mixtures. As you can see, with 1/4 dilution, we have a factor VIII activity of 6, and we did a residual factor VIII activity where 6 by your 85 is your 7%. So like that, we have calculated the residual activity in each of the tube, and you can see this 64.7 is closest to the 50% value, and it's happening with 1/16 dilution. So which dilution level is showing nearly 50% is 1/16. And what is the Bethesda label for 64.7 residual activity is 0.65. And what is the inhibitor level? 0.65 into 16. So that counts it to 10.4 Bethesda unit is the inhibitor level present in this patient. So what the guideline says? The guideline says test should be done after a washout that ensures that the baseline factor levels has been reached. How do you know that washout has been happened? By looking at a factor VIII level which is less than 0.01 or less than 1%. And with currently available methodology, it is difficult to accurately monitor factor VIII half-life in patients with a low titer inhibitor in routine clinical practice. If required, a half-life should be measured by the method described in International Immune Tolerance Study. Patient with mild or moderate hemophilia, or in those cases there is a factor VIII replacement has been done, but it has not come to the baseline, that is not below 1% label. The factor VIII can be removed by heating the sample at 58 degrees centigrade for 30 minutes. But the inhibitors will not be removed. Now you have made it below 1%. Now you can easily do a inhibitor assay in those cases. So how do you do an inhibitor assay or inhibitor in case of mild to moderate hemophilia or those severe hemophilia where factor VIII activity is still more than 1% because of factor VIII replacement? By doing a heating experiment. The inhibitor that has already been complexed with factor VIII will not dissociate from the complex during heating, and only free circulating inhibitors will also be there, and they can be measured by this test. So there are inhibitor assay. What we have discussed, most of the lab they do a one-stage assay, which is a clot-based assay, doing an APTT-based Factorate assessment. There is another assay that can also be done is a chromogenic assay. So that's the reason I have presented in this slide one-stage assay versus chromogenic assay, because there can be discrepancy that has been reported with low inhibitor titer range. And in those cases, a chromogenic assay may appear to correlate better with the clinical phenotype. And this chromogenic assay depends upon the factor 10 activation directly. So it is bypassing your factor 8 action of all interest, which is the rate limiting in the clot based assay. And it is also insensitive to lupus anticoagulant or directly acting oral anticoagulants. And it is not necessary to test each patient sample in several dilutions in there whenever you are doing a chromogenic assay. And approximately 20% patients with a non-severe hemophilia A, there can be a twofold higher one-stage assay level compared to the chromogenic assay. So there is a false high level of antibodies can be reported in here if you are doing a clot-based assay. In those cases, maybe a chromogenic assay is a better test. There are other assays are also available, but they are not commonly being performed. There are immunological assays, so they can be an alternative approach to improve the sensitivity of antibody assay. They can be used that remove several of the drawbacks of one-stage assay in the Nijmegen-Bethesda method. For example, the potential interference of other antibodies, including lupus anticoagulant or heparin contamination in venous access devices, or activity of other coagulation factors, and they also provide a possibility of detecting the presence of non-inhibitory antibodies. So all types of antibodies can against a particular factor can be measured in an immunological method. There can be no discrimination between an antibody with or without inhibitory activity, and an immunological assay should thus be considered an important additive, but they are not only the diagnostic tool. Most frequently, they can be done by ELISA. Then now there are flow-based assay are also available. This can be performed. So, how do you then approach inhibitor analysis in the lab? Do a factor 8 activity. If it is lower than expected with or without clinical symptoms, do a Nijmegen-Bethesda assay. So, factor 8 activity can be detected by your inhibitor screening method. If there is as expected and screen are negative, you may not do any further testing. Nijmegen's Bethesda assay or classical Bethesda assay, if they are below the cutoff is 0.6 Bethesda unit, you can further do an immunological assay. If they are negative, no further testing is required. If they are positive, you can do a IgG subtyping. If they are above the cutoff, no requirement of an immunological test. Just report the inhibitor levels. But you have to keep in mind what are the acceptable criteria or guideline that has been set for an inhibitor assay. So coming to our case, as you have seen, our case have inhibitors and inhibitor level was 10.4 Bethesda unit. So how does these patients with inhibitor present? They can be detected either by a routine laboratory testing or by doing the mixing study or inhibitor screen or by clinical presentation. An inhibitor can be clinically suspected whenever the patient experiences bleeding that does not adequately respond to the hemostatic therapy. And it is also prudent to check an inhibitor titer level prior to any invasive procedure to ensure adequate hemostasis. Once you have detected inhibitor, based upon the level of the inhibitor, they can be a high titer inhibitors or the low titer inhibitors. High responders versus low responders. Whenever the titer of the inhibitors are more than 5 Bethesda unit per ml, then we call it high titer inhibitors. Whenever they are less than 5, we call it low titer inhibitors. And what are the risk factors then? The risk factors can be mutations, but particularly specific mutations are there which are more have a more propensity for immunological response. A positive family history of inhibitor, type of factor 8 mutation, Intensity of factor VIII infusion, if you are putting the patients on more frequent, there is a chance that can develop factor inhibitors. Younger age at first exposure to factor VIII is another factor, and type of factor VIII concentrate, that is plasma derived factor recombinant, and recombinant factors develop more commonly with a inhibitor. But yes, there are literatures which shows an equivocal results too. So, looking at this table, what are the risk factors then? The genetic mutations who are at high risk are large deletions like intern 22 inversion, nonsense mutations, they are more commonly exposed for development of inhibitor, family history, African or Hispanic race or ethnicity, or immune response traits, particularly some types of HLA type 2 complexes are more commonly associated with the development of inhibitor. That can be polymorphism of the cytokine like interleukin or tumor necrosis factor alpha. They can also develop more commonly inhibitors in hemophilia A patient. What are the environmental risk factors? The intensity of the fast factor VIII exposure. Either there is a surgical procedure where you are giving a lot of factor VIII, then there is an increased propensity. The higher frequency or younger age can lead to development of inhibitor. There are inconclusive, the results are there in different, which requires further study, maybe a source of factor VIII, plasma derived versus recombinant, or early prophylaxis to prevent inhibitor formation are other inconclusive factors. So, what is the immunology of inhibitors in hemophilia A? It is very similar to any immunological reaction. First, there is a central tolerance for the deficient protein. After that, there is a first exposure which develops a primary immunological response, followed by subsequent exposure leading to secondary immunological response and antibody development. These cartoons are depicting what is actually happening. So the first part is your central tolerance to the deficient protein. So as you know, the immature T cells enter the thymus and interact with the thymic epithelial cell, and T cells that do not recognize the self antigen can be presented by the class 2 HLA, and T cells that are recognized by the self antigen can be presented by class 2 HLA, and they will undergo apoptotic death, and which are do not recognizing, they can produce the signal for survival. And so what is happening in hemophilia A? Because the factor VIII is deficient, so these T cells are not exposed to the factor VIII, so the autoreactive T cells which are undergoing death may not happen. And because it is not happening, so when there is a factor VIII replacement, they are being considered as foreign to the body, and there can be an antibody reaction. So that antibody reaction goes through the similar process of the primary response, where there is activated T cells presented to the B cell, and that are in the B lymphoid follicles, and they will start proliferating and dividing and forming the plasma cells, and the plasma cells will do the secretion of your factor VIII antibodies, and they will also produce the memory B lymphocytes. So whenever there is a subsequent exposure, these memory B lymphocytes will produce activated B lymphocytes and more in number of plasma cells and more antibodies in a repeated exposure, and there will be more development of inhibitors against factor VIII. So that's what is being depicted in this graph, the first exposure versus a repeat exposure. So how you are treating? You are treating by two mechanisms. Basically, one is one has to use the bypass agents like activated prothrombin complex concentrate, that is PCC, or activated recombinant factor 7 are needed to treat or prevent the bleeding episodes in hemophilia A patients with high titer inhibitors. There is recently available emicizumab, is a non-factor therapy that is approved for prevention of the bleeding in patients with hemophilia A with inhibitor. The second type of the therapy or modality of the therapy in case of inhibitor development in hemophilia A is the immune tolerance induction. So what it is, immune tolerance induction is a unique available treatment for eradication of persistent high titer antibodies in hemophilia A, where you are giving the factor VIII replacement repeatedly. And it is almost effective in 60 to 80% of the patient. but it is a demanding and high cost treatment, and that is the main factor that prevent the clinicians from doing an immune tolerance induction in case of inhibitor development. So looking at the algorithm, how do you treat? There are inhibitors are more than 5 Bethesda unit. They are high responding inhibitor. You have to use bypass agents, or you can go for an immune tolerance induction, that is ITI. If there is a transient or low responding inhibitors are there, that means inhibitor levels are less than 5 Bethesda unit, you can increase the factor 8 or the 9 dose, or you can go ahead with a immune tolerance induction. There are some predictors of response in case of ITI. Predictors of success: if the pre-ITI inhibitors levels are less than 10 Bethesda unit, so there is a good chance ITI may succeed. If historical peak inhibitor levels are less than 200 or low factor 8 dose are being given, or what is the genotype? If there is a low risk mutations like a small insertion or deletion or missense, there is a good chance that ITI they can succeed in those cases. But scenarios are there where there can be failure in ITI if the interval of more than 5 years has gone from the diagnosis of inhibitor to start of ITI. If ITI has been interrupted, or there is a low factor ITI dose of has been given, or there is a high peak titer has been noticed from the very beginning, then there is a chance that ITI may fail. Coming to the inhibitors in hemophilia B, the almost it is very similar to those in cases of hemophilia A, but there are few points of difference are there. But how do you detect it? You are doing an inhibitor screening, and inhibitor screening will show immediate acting inhibitors. Time dependency is not seen in case of hemophilia B. The development of inhibitor in hemophilia B is a rare event. It can happen 1.5 to 3% of cases. Is associated with significant morbidity in comparison to hemophilia A. And what is the common morbidity? Despite the increased risk of bleeding, there is frequent occurrence of allergic or anaphylactic reactions and nephrotic syndrome that is seen in case of hemophilia B who are developing inhibitor. An induction of immune tolerance is often unsuccessful in hemophilia B, but can be otherwise affected by many other complications because the patients have allergy or anaphylactic reactions more commonly seen. So that is the reason which has made the study difficult in cases of hemophilia B for immune tolerance induction. Laboratory diagnosis, as I have told, by doing and looking into the inhibitor screen, by looking into immediate acting inhibitor, and you can do whenever inhibitors are there, like a Bethesda assay. So how do you manage those patients? First, you have to look into the diagnosis. You can do a molecular diagnosis early if it is available. You that differentiate into allergic phenotype versus non-allergic phenotype. Allergic phenotype, again, low responder versus high responder. Low responder, you can go ahead with a factor 9 replacement at administration. No bleeding control, you can go and look or for ITI with or without immunosuppressive therapy. In high responders, you can opt for an ITI with or without immunosuppressive therapy, or you can also give a recombinant factor 7. Allergic phenotype, bleeding treatment, you have to give bypass agents like recombinant factor 7 is recommended. If there is no bleeding manifestation, you can go ahead with an ITI if that is allowable. You can also consider factor 9 desensitization, combined immunosuppressive therapy, rituximab, but in those cases you have to do a frequent urine analysis as a control. No clinical response, you can go for plasmapheresis or immunoadsorption, or recombinant factor 7A or activated factor 7, Novo 7. Next, after allo antibodies, coming to the acquired coagulation inhibitors associated bleeding disorder, those are all auto antibodies. Acquired coagulation inhibitors, also known as circulating anticoagulants, are antibodies that bind to coagulation factors and neutralize their activity or accelerate their clearance. They can develop spontaneously in normal subjects. Normal means they do not have an inherited coagulation factor deficiency where no documented coagulation abnormality has been seen in these cases, and they can be designated as autoantibodies. What are the different disorders? These disorders are very rare, but in literature, it has been reported against the primary hemostatic conditions like acquired von Willebrand disorder has been reported, acquired GT, acquired BSS. Those are against your glycoprotein 2b3A in cases of Glanzmann's thrombasthenia, or glycoprotein 1b9 in case of an acquired BSS. Where you will see the antibodies are autoantibodies are formed and they are leading to bleeding disorders. Similarly, they also involve your secondary hemostasis, where antibodies have been reported against almost all factors, but most commonly are seen in as an acquired hemophilia A followed by an acquired hemophilia B. So, what are the conditions that can lead to acquired hemophilia A or acquired hemophilia B? There is a number of conditions are there. As a list is an endless list. What are the common associations? The common associations are immunological disorders like commonly the SLE or Sjogren syndrome. Usually they have a very high titer inhibitors associated with them. Hematological malignancies. So whenever in an old age patients you are doing an APTT test or PT test that is prolonged, and you are doing a mixing study and mixing study is not getting corrected, that indicates inhibitors are there. Please work up for a malignancy, underlying malignancy, because underlying malignancy, hematological malignancies or solid tumors can be associated with acquired hemophilia A. Pregnancy sometimes can present with a transient acquired hemophilia A like manifestations. So how do you investigate? Investigate is based upon the same principle. First and foremost is clinical history, the pattern of bleeding manifestations, and the age of presentations, the family history, etc. Based upon that, look also into the drug history to exclude the anticoagulation therapy, including your DOACs, NOACs, where you can look into thrombin time or anti-10A assay. So all those cases, if the positive history, what you have to do, you have to do the screening tests, that is PT and APTT, and the fibrinogen. If your PT is prolonged, the next step, what you is your mixing study. And I, by this time, my presentation, everybody, I think, who are establishing their lab have doing or only PT or APTT, they can do a mixing study. If mixing study shows correction, that indicates factor deficiency. PT showing only isolated PT with correction. So most commonly patient might be having a factor 7 deficiency. Do a factor 7 assay. You can also consider low levels of other factor deficiencies. You can do those assays if required. If it doesn't correct, so there is no PT correction, prothrombin time correction in the mixing study, you have to look for factor 7 assay for a low value or non-parallelism, and do a factor 7 inhibitory assay. So it will be also same like a Bethesda assay. Only thing is that you have to do a PT based assay. You can also consider lupus anticoagulant. Coming to the APTT only prolonged, so isolated APTT prolongation, you can look into thrombin time, exclude heparin, do a immediate mix that is showing correction. So that can be a factor deficiency. You can do a factor 8 and 9 and 11 assay. You can need not do a factor 12 assay because, as I have already explained in my previous presentation, factor 12 deficiency does not cause bleeding disorder. Factor 8, if it is low, if it is non-parallel, you can do a mixing study by doing an incubated mix versus a fresh mix. If your screen is positive, you can do a factor 8 inhibitor assay. Also, what you have to do, you have to do a recuff, that is look for von Willebrand activity, because von Willebrand factor whenever they are deficient, they can also reduce your factor 8 levels, because factor 8 getting stabilized by association with von Willebrand factor. And you can do a 9 and 11. If they are low or non-parallel, you can do a inhibitor assay. If your mixing study does not correct, definitely there is an inhibitor is there. If you are dealing with a known case, you are not you are not dealing with a known case, so you have to look for a time dependent and temperature dependency. If that is there, you have to do a factor 8 inhibitor assay. If immediate only is prolonged, you still do a factor 8 assay, because as I have told you, high titer of factor 8 inhibitor can also do not show a correction with an immediate mix. You have to should also do a 9 and 11 assay for look for those inhibitors too. Whenever both and PTAP, APTT are prolonged in an acquired condition, please think of patients might be having a DIC. So you have to do is exclude DIC, look into the clinical condition, clinical history, look for injection site bleeding manifestations, and do a D-dimer. If D-dimer levels are high, then your diagnosis is straightforward. Otherwise, you can still do a mixing study, correction versus no correction, and look for the in no correction, look for the inhibitors and the lupus anticoagulant. So this is how the algorithm that present how do you investigate an acquired inhibitor. Coming to the case scenario 2 is a 30-year-old female who was referred to our department with deep venous thrombosis. She had a history of loss of pregnancy previously. We did an APTT test using an actin FSL, which shows 42 seconds. We did with our where our reference range is 24 to 35 second. We did an APTT mixing study which is not showing any correction 40 second. But when we did an APTT test with another APTT reagent which is actin FS, you can see the APTT is normal. So what is the basic difference between these two reagents, actin FSL versus actin FS? Actin FSL is a low phospholipid containing APTT reagent. Actin FS has a high phospholipid containing APTT reagent. So by presenting this case, what I am trying to convey is that I am trying to convey that your APTT reagent or nature of the APTT reagent what you are using is also important in the lab, because some of the your reagent you may not be knowing may have a low phospholipid, by which you make it a lupus sensitive reagent or phospholipid antiphospholipid antibody sensitive reagent. And these cases or these scenarios when patients are being screened in case of a pre-operative screening may lead unnecessarily to the factor replacement, thinking that there is a factor deficiency, but actually there is a inhibitor against the phospholipid, so that you need to be aware of. So with this case scenario, what we have proved that the inhibitors show a phospholipid dependence, because actin FS is rich in phospholipid which is correcting it. And in such scenario, these conditions are known as lupus anticoagulant. This lupus anticoagulant is a misleading term. I will be just focusing on the laboratory aspect of the lupus anticoagulant. And most patients do not have SLE in lupus anticoagulant, but patients with SLE are more likely to develop lupus anticoagulant than the general population. And it is an in vivo abnormality because it is a procoagulant. So it's a misnomer. So that's the reason I called it as a misleading term. It is a procoagulant, and patients with lupus anticoagulant actually show a thrombosis. They do not show bleeding manifestation. But why then anticoagulant? Because it accurately describes what is happening in vitro in your laboratory setup. So that what I have shown you in my case. So this is what is happening in vitro anticoagulation, where the antibodies are interfering with the phospholipid used to induce coagulation. But in vivo, what happens? These antibody interact with the platelet membrane phospholipid by the virtue of which there is increase in adhesibility of the platelets and aggregation of the platelet, and they make inside the body a procoagulant condition. So lupus anticoagulant, the emerging picture is an immunoglobulin bind to phospholipid and protein associated with the cell membrane, and is an antiphospholipid antibody that interferes with the binding of the prothrombin with the prothrombin activator. Antiphospholipid syndrome is an acquired multisystemic autoimmune disorder They show presence of persistent antiphospholipid antibodies. They can be lupus anticoagulant versus they can be anti-cardiolipin antibodies or anti-beta-2 glycoprotein antibodies type 1. They can be primary de novo, they can be secondary associated with other autoimmune diseases, or they can be catastrophic antiphospholipid syndrome. Clinically, they present two kinds of presentation. Number one is a thrombosis, or number two, pregnancy complications or failure. In thrombosis, there can be an arterial thrombosis or venous thrombosis or DBT, or there can be a microvascular thrombosis, which is less common. And potentially, microvascular thrombosis are more commonly seen in catastrophic antiphospholipid syndrome. Pregnancy complications can present as an unexplained fetal death more than 10 weeks or premature delivery more than 34 weeks, or there can be spontaneous abortion less than 10 weeks. So, what is antiphospholipid syndrome? As I have told, sorry, I went back. So, what happens in case of lupus anticoagulant or antiphospholipid antibodies? They can act on the coagulation pathway, which happens really in vitro, and the main action is against the prothrombinase complex. And because they are acting against the prothrombinase complex predominantly, so there is prevention of thrombin formation and the clot formation. So, if you are using a lupus sensitive reagent, your APTT will happen to be prolonged. Even your PT can show prolongation. And anti-prothrombin antibodies protect prothrombin from inhibitory effect of thrombin 3, and they what happens in vivo, and that will increase the coagulation. It can also involve the protein C pathway, where autoantibodies against the thrombomodulin protein C and protein X can act, and they will produce a procoagulant nature. So this is the beta-2 glycoprotein 1 molecule and the antibody that are being formed in these cases. So when you diagnose Apla syndrome, so there are some criteria are there. There should be at least one or more clinical criteria. Clinical criteria involves vascular thrombosis and pregnancy morbidity. Vascular thrombosis, there should be at least one or more objectively confirmed episodes of arterial, venous or small vessel thrombosis occurring in any tissue or organ. Pregnancy morbidity, there can be one or more unexplained death of a morphologically normal fetus at or beyond 10th week of gestation, or one or more premature birth of a morphologically normal neonate before 34th week of gestation because of eclampsia, preeclampsia or placental insufficiency, or three or more unexplained consecutive spontaneous abortion before the 10th week of gestation. Laboratory criteria, it also requires one or more of the following laboratory criteria on two or more occasions at least 12 weeks apart, using recommended procedure. Lupus anticoagulant should be detected according to the guideline of ISTH, or anti-cardiolipin antibody of IgG or IgM isotype present in medium or high titer, or anti-beta-2 glycoprotein 1 antibody IgG or IgM isotype present in 99% measured by standardized ELISA method. So at least one clinical, at least one laboratory criteria must be fulfilled to give a diagnosis of antiphospholipid antibody syndrome or APS. So that is what is the picture where depicted how it is diagnosed. So as you have understood, the antiphospholipid antibodies can be detected by two types of assay. If you are doing a coagulation assay, you are detecting a lupus anticoagulant. If you are doing a solid phase assay, you are trying to detect the anti-cardiolipin antibodies and or beta-2 glycoprotein 1 antibodies. So because it's a hemostasis testing, we are focusing, so more focus on lupus anticoagulant testing. How do you select the patient who should be tested? Clinical characteristics that can be categorized into low risk, moderate risk, and high risk. Low risk is venous thromboembolism or arterial thrombosis in elderly patients. You may not go ahead with the lupus anticoagulant testing. Moderate risk categories are those with provoked venous thromboembolism in young patients, and there is a high risk that they can have a lupus anticoagulant if there is an unprovoked venous thromboembolism or arterial thrombosis in younger patients less than 50 years. So whenever there is a high risk of lupus anticoagulant, those are the major patient, those where you should go ahead with the lupus anticoagulant testing. Similarly, the prior history of pregnancy loss, where those patients also you can screen for a lupus anticoagulant. Warning is that or this you should not have a generalized approach, a generalized search in case of an asymptomatic patient for lupus anticoagulant that can unnecessarily increase your false positivity rate. So, young patient presenting with ischemic stroke, go ahead with the lupus anticoagulant testing. Patients with unprovoked DBT or pulmonary embolism, you can go ahead with the lupus anticoagulant testing. So, what are the pre-analytical variables you should be careful? That is most important. So, that helps you in designing your lab protocol. Number one, you have to collect a fresh venous blood sample that should be collected with 0.109 mole per liter of trisodium citrate in a ratio of 9 is to 1, where 9 part of the blood should be added to 1 part of the trisodium citrate anticoagulant. Patients should be free of any anticoagulant intake. Then you have to do a double centrifugation at 2000 G for 15 minutes at room temperature to create platelet poor plasma. So if I will ask why platelet poor plasma, because if the plasma is rich in platelet, when you do a thaw or when you do an agitation, they will disintegrate. And these platelets are rich in phospholipid. So you are falsely making the sample phospholipid rich, for which you cannot prove phospholipid dependency to diagnose lupus anticoagulant. So that is very important. Whenever you are doing a test, going ahead for a test for lupus anticoagulant, do a double centrifugation to make a platelet poor plasma. So what is the quality control measure to understand that platelet is poor in the plasma? Your final platelet count should be less than 10,000. Samples should be frozen immediately by doing a snap freezing or immediately put into minus 80 degrees centigrade, and before testing the sample should be thawed by keeping it in water bath at 37 degrees centigrade for 10 minutes. And sample which are thawed cannot be refrozen or cannot be tested later on. You have to do the lupus anticoagulant testing immediately. And what is the test approach? It is again a three-step approach. What is the three-step approach? The first step is screening, second step is mixing, third step is confirmation. You cannot forego or you cannot avoid any step whenever you are looking for a lupus anticoagulant. So what is screening? Prolongation of phospholipid dependent clotting tests. That means low phospholipid content. If it is there in your reagent, that will show a phospholipid dependent clotting test, that is by which you will show or do a screening. Then you do a mixing to demonstrate there are inhibitors by showing non-correction of the clotting test by doing a mixing study. Then how do you confirm? By demonstrating phospholipid dependence, so making the reagent rich in phospholipid, which will confirm that yes, there is a phospholipid dependency is there, antiphospholipid antibodies are there. There are different tests are available. You can do a dilute prothrombin time. You can do a dilute rhesus viper venom test or DRBBT. You can do a lupus anticoagulant sensitive activated partial time testing, that lupus sensitive APTT or kaolin clotting time. So how do they act? The silica clotting time, kaolin clotting time, or lupus sensitive APTT, they act on the intrinsic pathway above the common pathway. Dilute prothrombin time acts on the extrinsic pathway. DRBBT acts from formation of the activated 10A onwards. So that is the reason it is that one of the tests that you must do to detect lupus anticoagulant is DRBBT. So the mechanism as depicted, DRBBT test below the formation of 10A onwards. So it really looks into the formation of the thrombin. So that is the reason it is a better test for detection of lupus anticoagulant. Advantage, the DRBBT is unaffected by abnormalities in intrinsic or extrinsic pathway or coagulopathies or inhibitors are there. Disadvantage is affected by abnormalities in the common factor pathway deficiencies like 10, 5, 2 or 1. Kaolin clotting time, it involves intrinsic and common pathway, sites of phospholipid requirement in the coagulation cascade. Only kaolin is used for contact activation, no platelet substitute is being added. and test is affected by clotting factor deficiency and anticoagulation therapy. And the range of mixture is required. Depending upon different range of mixture, you can put it into the graph, and from this graph you have to calculate the ratio of the kaolin clotting time with 80% of the normal plasma with 20% of the test divided with the kaolin clotting time in 100% of the normal plasma. If it is more than 1.2, it has been considered positive for the lupus anticoagulant. So coming to the second step, mixing. Mixing should be done using patients and the normal pooled plasma. Persistence or prolongation of the coagulation time indicate presence of inhibitor. Guideline says PNP of mixing studies should ideally be prepared in-house. Adequate commercially lyophilized and frozen PNP can alternatively be used. 1:1 proportion of the patient and PNP can be used without pre-incubation. Within 30 minutes, you should do a test. Once inhibitors have been established by doing a mixing state, you have to do a confirmatory test which shows correction of the prolongation by addition of the phospholipid reagent. And what is this phospholipid reagent? It can be a platelet neutralization test or hexagonal phospholipid assay. Some of the reagents come with an integrated kits like DRVBT having both screen and confirm reagents, so which makes your job easier. Guideline choice of test, you should do 2 tests based upon different principle. More than 2 tests unnecessarily will increase your false positivity rate, and one of the tests that you must do is a DRVBT is the first test to be considered. The second test can be either an APTT, low phospholipid or silica as an activator, and lupus anticoagulant should be considered positive if one of them gives you a positive result. How it is expressed? It is expressed by doing a ratio calculation, that is screen by confirm. If your screen by confirm ratio is below 1.2, then it is considered negative. It is more than 1.2, it's considered positive. 1.2 to 1.5 considered as a mild positive for lupus anticoagulant. 1.5 to 2 moderate, and more than 2 is considered as a marked positive for lupus anticoagulant. And you have to confirm it within 12 weeks by doing a repeat, after 12 weeks by doing a repeat testing. But scenarios are there where the different kind of laboratory results you may obtain. The first scenario, you have to do a LA screen and LA confirm. You have a patient's plasma, then your patient's plasma with your pooled plasma. LA confirm, you have again patient plasma and pooled plasma. That is your mixing study. If all the 4 results, that is LA screen mix, LA confirm mix, all are normal, lupus anticoagulant are not detected. LS screen abnormal, mix abnormal, inhibitors are there. LA confirm is normal, you do not require a mix, then you think that the lupus anticoagulant is present. Scenario may happen when LS screen is abnormal, but when you do a mixing, it becomes normal. Confirm is also abnormal, when do a mixing, it becomes normal. That means the mixing study shows there is a factor deficiency, lupus is not there. Conditions where LS screen are abnormal, screen mix is abnormal, confirm is abnormal, confirm mix is normal, that indicates look into the ratio, lupus anticoagulant is there. In addition, there can be a factor deficiency associated with it. If all the 4 are abnormal, you have to look for other inhibitors. Lupus anticoagulant may not be there. So there are different guidelines are there to how to detect lupus anticoagulant. If patient is on the vitamin K antagonist, if your INR value is less than 1.5, you can do a DRVBT and a FPTT based test. If 1.5 to 3, do a mixing 1:1 and then do the test. If INR is more than 3, you cannot perform a lupus anticoagulant testing. Similarly, other secondary testing can be done by using type and snake venom testing, eccrine time, platelet neutralization process that has been recommended by the British Society. If patient is on anticoagulant therapy, you should have a caution when interpreting results. Patients who are receiving unfractionated heparin, and LA testing should not be undertaken in patients receiving therapeutic doses. So guidelines do differ. There are some certain differences, and that I have depicted in this table. Because of time, I am not going through the complete table. There can be scenarios where you can get a transient lupus anticoagulant. So how you will know that there is a transient? Repeat after 12 weeks. If that becomes normalizes, there is no lupus anticoagulant, it can be a cause is a transient lupus anticoagulant. This happens in cases of any acute phase reactant proteins are being elevated. So pitfalls of lupus anticoagulant, that can be false positive rates cut off 99 percentile, two phospholipid dependent assays, three steps you have to do. You cannot do in acute phase. You have to do a repeat testing. Patient characteristics are important. Anticoagulations, UV causes and specific coagulation factor inhibitors can also be there. False negative results can be obtained in case of an improper plasma preparation, diluting effect of mixing study, or the ABK therapy is you are going ahead. What is the association of thrombosis with lupus anticoagulant versus an antibody test? If both are negative, only GPI proteins are there. There is no association with thrombosis. If anticardiolipin antibodies are only positive, there thrombosis is less common. If only lupus antibodies, thrombosis are less common. But thrombosis are more if all the three are positive. So we call it triple positive, which have a very high risk of thrombosis and pregnancy loss. If lupus anticoagulant negative, but with anticardiolipin antibodies and anti-beta 2 glycoprotein also modest, they can also have a thrombotic risk. So with this, to summarize, most important test for detecting inhibitor is doing a mixing study. Mixing study showing correction, there is a factor deficiency. Mixing study shows no correction, there is an inhibitor, label are there. In case of a suspected factor 8 inhibitor, you have to do so the time dependency by doing an inhibitor screen where you look into incubated mix versus a immediate mix. If it is more than 10 seconds, do a inhibitor assay, Factorate inhibitors are there. So with this, thank you. I will glad to take any questions if it's there.
Right. Thank you so much. A wonderful lecture as usual. And what is most important in all this is you have to know the algorithm very well. It's all
Very well.
mathematics.
Yes,
And,
yes,
and have your PT and APTT very well standardized.
yes.
Because that is the key. And all the tables which you showed, the all the algorithms are so important because one has to know exactly what results will take you which way. Dr. Rajesh, you are a wonderful teacher, very well explained, very nicely and in extreme depth. Very nicely done. Just let me
My,
check on the YouTube if there are any questions.
sure.
All right, there are no questions on the YouTube. So thank you so much, Dr. Rajesh, for taking out time after an episode of illness and to take a 1.5 hours strong lecture. Thank you so much. Wonderful.
Yeah.
We will invite you maybe sometime after 2, 3 months to take another lecture or maybe a case based study